Here at the 2014 ATS conference in San Diego, California, happy to have with us Dr. Paul Forfia from Temple University. Thanks for being here, sir.
Thank you for having me.
So you moderated a session titled Clinical Assessment of the Right Ventricle and Pulmonary. In your opinion, what was a highlight or perhaps a theme of that session?
Sure. So, there were multiple talks in the session, and I would say that probably the thing that I was most happy to see was that there were multiple talks that were targeted toward the assessment of the right ventricle and, more importantly, the relationship between right heart function and pulmonary vascular load in patients with pulmonary arterial hypertension. And that relationship we called RVPA coupling, or right heart pulmonary circulatory coupling. And that relationship is likely central to the assessment and the reassessment of patients with PAH. And there were several studies showing that if the right heart is improving at the same time that the pulmonary circulation and the pulmonary vascular function is improving, that is the best way, it seems, to be monitoring these patients on therapy.
And so this theme, if you will, shows that your colleagues are all kind of going around the same area or thinking the same thing?
Yeah, I think it reflects an evolved understanding of the central pathophysiology of PAH. We're moving away from thinking about pressure assessment, and we're even moving away from more surrogate markers of reassessment of the disease and really targeting the true pathophysiology of PAH. And then we're trying to do it in a way that we come up with ways that are digestible, that are practical to use in the clinic.
Why is evaluating the right heart so important in PAH?
Well, even though the disease PAH starts from within the lung, changes in vascular tone, vascular caliber, vascular proliferation, that leads to increased load in the lung circulation, the morbidity and the mortality of the disease is largely conferred through how the right heart adapts to that load. And so, as such, it is critically important that when we assess a patient at baseline, when they're therapy naive, and then perhaps even more importantly, once they're put on therapy, we want to watch and assess that right heart. We want it to get smaller. We want the RV function to improve. And I think that as our field moves towards more of a right heart-centered model of reassessment, our therapies will evolve and the prognosis for the condition will improve.
New approaches in this area to you, which one seems to have the most promise?
Yeah, I think that when we think about assessing the right heart, there are multiple modalities that can be used to do this. And so it's not an easy question to answer if you're asking, well, like, what is the single best way to do this, okay? I will say that thematically, what is likely best is reassessment of the right heart in a way that is simple and practical, but also powerful. And I can compartmentalize assessing right heart function using three modalities briefly: echocardiography, and then cardiac MRI, and then hemodynamics. Echocardiography is a workhorse method of imaging of the heart and imaging of the right heart, and I think holds a tremendous promise in our ability to assess and reassess the right heart in response to therapy. And there are several ways that have emerged that are relatively simple and practical and robust. And so we as clinicians need to understand that we do have echocardiographic tools that are simple and reliable and have powerful prognostic information. And it's very important that the literature really build in this area. Yes, go ahead.
Go ahead, continue.
Thank you. So MRI is another powerful way to assess the right heart by imaging, and there's some very nice data now showing that following RV ejection fraction in patients on therapy is a very powerful way to assess patients, and namely that their RVEF exceeds 35% on therapy. And then lastly, hemodynamics. And so if we're going to recath a patient with PAH, we should be paying the most attention to the hemodynamic parameters that reflect right heart function: stroke volume, cardiac index, cardiac output, these are the critical measures we should be looking at. It doesn't mean that we're ignoring mean pulmonary pressure or right atrial pressure, but instead that our central focus be on true measures of improved right heart performance.
Thank you, sir. I can tell you're passionate about your work. I wish you the best, and thanks for stopping by and sharing your insights.
Thanks for having me. I appreciate it.